Thank you, everybody, for joining us in session 1.2 on aortic stenosis and TAVR. In this session, we're really going to be focusing on the full spectrum of TAVR, from patient selection in low risk patients to the growing challenge of failed TAVR and redo interventions. I'm lucky to be joined by an incredible panel. John Forrest from Yale, New Haven. Thanks, John, for joining us. Anton Kamash from Mount Sinai. Anton, thank you. And my very good friend, Ahmed Krishnaswamy from Cleveland Clinic. Guys, really appreciate you taking time out of your day for this. It's great to have you. We're going to go straight into it. So I want to make sure we have time for discussion. So, John, why don't you kick it off on really how you think about patient assessment for low risk TAVR?
I will note that we're over here in New England. There is things north and east of New York as you start to expand more. So we're cut off a little bit from the TIO slide, but that's where we are there. So I thought I would talk a little bit about our patient assessment and how I look at low risk patients. And from there, here are my disclosures. With regard to low risk TAVR, sort of practical patient assessment, I think there are three main parts to that. There's the anatomic assessment of the patient. There's the assessment of lifetime management, and as you're looking at the patient. Then I think the other important part is patient preference and shared decision making. I do want to start with patient preference and shared decision making, and I think for the majority of patients, we tend to follow the guidelines and think about it in this regard as it relates to choosing between a surgical aortic valve replacement and a transcatheter replacement. When the patients are less than 75, we tend to favor surgery. When they're between 65 and 80, we tend to favor a shared decision-making approach. And when they're greater than 80, we tend to favor a transcatheter approach. I will say that there are patients who are less than 65 who for various reasons may choose a TAVR first. And I think it's important to have those conversations with patients. But I think the other really important thing here is that the role of the physician in shared decision making is not only to share their knowledge with the patient, but this knowledge needs to be about both the data, and it needs to incorporate patient specific characteristics that are going to impact outcomes. And let's talk a little bit about that. So aortic valve anatomy, we have tri-leaflet valves and we have bicuspid valves. One of the important things I would say is one may look at these two and say, the tri-leaflet valve, let's do a TAVR in that, and the bicuspid valve, maybe we should do surgery. But the fact of the matter is, if you go down to the annulus of this bicuspid patient, this actually will do great with a TAVR. You go down to the annulus of this tricuspid patient, this is not going to do well with a TAVR. And if both these patients are low risk, you need to appreciate that. It really, I think, and more data is showing this, that the number of leaflets matter much less than the distribution of calcium within those leaflets and at the level of the annulus. When we talk about aortic anatomy, obviously aortic aneurysms, something that we can't treat well with transcatheter therapies, and not good for TAVR there. And similarly, porcelain aortas, you have some low risk patients who have these, and that's not going to be good for a surgical aortic valve replacement. So understanding the aortic anatomy is critically important. As it relates to the femoral anatomy, I think in patients who are low risk, if they have transfemoral access, that's the way to go. And I think that's really where low risk is. It's fun to do transcaval cases. They're a lot of fun, but really cases like this, I think, should be reserved for patients who are not low risk for surgery. And in general, we try to avoid alternative access in low risk patients, especially if they're low risk for surgery. Now, if the patient has a porcelain aorta, it may be a different scenario. But in patients who are truly low risk for surgery, we don't enjoy doing, and I don't think it's necessarily the right thing to do, an alternative access TAVR in those patients. What about coronary anatomy? And that's another thing. I think there's been more data that has come out recently that has shown over the long term, and this is looking at the Notion 3 data, that you're going to have benefit from revascularization. And that's really important, I think, in younger patients, especially in low risk patients. I think our approach in lower patients is that if they have significant coronary disease, that revascularization should be performed. And when we think about revascularization in these patients, if revascularization would be best with a CABG, which in our institution often involves distal left main disease or triple vessel disease, in a low risk patient, that patient we think would be best served with a CABG and a surgical aortic valve replacement, especially in a younger low risk patient. Just because they may have great TAVR anatomy, it doesn't mean that you should then say, well, let's do a PCI in this. If they would be better served with a CABG long term, then that is probably a very reasonable way to go. So what do we know beyond 5 years for the results in low risk studies? So the partner 3 data is now out to 7 years, and you can see very similar outcomes in terms of all cause mortality. This is using the vital status sweep between transcatheter aortic valve replacement and surgical aortic valve replacement. The Evolut data is out to 6 years, and similarly, you see very similar, not statistically different outcomes in all-cause mortality or disabling stroke here, looking at the Evolut out to 6 years between surgery and transcatheter aortic valve replacement. That being said, there were some findings that we recently published about the Evolut data showing that there is a difference in reintervention. So this is looking at cumulative reintervention through 6 and 7 years. And you start to see that there's a statistical difference that pops out where there's more reintervention that's needing to be performed in the TAVR arm than in the surgical arm. And I think that's important. And I think we can take both the partner 3 data and the Evolut data, and we can conclude from that that it appears unlikely that a TAVR valves will last significantly longer than surgical valves. And redo TAVR is often more challenging than a TAV and a SAV. As a result, when we approach these patients, we believe it's important to plan for a second valve at the time of the first in patients who are less than 80. And in some patients, their anatomy may be feasible for a TAV or for a TAV and TAV, but in other patients, it may not be feasible. And figuring out ways to predict this and plan going forward, I think, is very important. We'll have some cases and presentations about that coming up. But the more that we can look at that up front, I think helps us plan for the future. So with that, I'll finish there and turn it over to my colleagues.
Thanks, John. Really appreciate that. And again, a reminder to the audience, please send us your questions. We talk about it. Amr, I mean, maybe one of the things, just because that's how we ended with John talking about some of the longer term durability data. When you see this data, has it had caused a moment for you to pause, to change what you're doing as far as valve selection at all? How are you interpreting all this new long-term data?
Got it. Thanks, Azim. By the way, can you guys hear me?
Yes, we can.
So,
You
I first of all,
frozen,
great
but we can hear
presentation,
you.
John. Nice going through the data there. I think the most relevant thing for me always is to understand what the suitability is for a future intervention for the patient, especially if we're talking about the low risk group. And I think that there's plenty of data to demonstrate that both of the major commercial valve platforms provide equivalent results. But I think it's really important that operators really look at the CT scans, potentially themselves if possible, so that at the index procedure, that whichever valve platform you're using is not just good for that time, but also to understand what are we capable of doing in the future. And I think if there are those patients in whom neither valve platform is going to allow a future TAV and TAV, I think that's really where the surgical treatment may hold the most value.
Yeah, great. Thank you. I'm smiling. I just saw my daughter. Always gives me a smile. So another question that keeps coming up, maybe I'll address this to you, John, is what are you doing about low risk patients with bicuspid anatomy? What is your approach? I mean, you went through a lot of the challenges we see with large aortas and so on, but
Yes.
when you see a patient who's low risk and has a bicuspid, just take us through some of your thinking.
Yeah. So, I think the way I approach bicuspid valves is actually fairly similar to the way I approach tri-leaflet valves, except that we know that there's going to be some red flags that pop up a little bit more frequently. And so you need to be aware of those, right? You're going to have a higher incidence of aortic aneurysms with bicuspid valves. You're going to have a higher incidence of sort of hostile leaflet calcification with bicuspid valves. You may have a higher incidence of even annular calcification with bicuspid valves. But if you actually look at I think we can predict those pretty well in bicuspid anatomy. If you look at the partner and the Evolute low risk bicuspid data, you see that the outcomes in both of those studies were equivalent, if not actually slightly better than we're seeing with the tri-leaflet valves. And so the presence of a bicuspid valve itself doesn't push me in one way or another, but it is important to recognize that it tends to be associated with more hostile anatomy than a tri-leaflet valve. So that can be assessed. There are some nice studies that are starting up that are finally going to randomize bicuspid low risk patients to surgery or transcatheter aortic valve replacement. And I think that'll be important, and we'll go from there. But I tend to be honest, approach them fairly similarly, just recognizing that there's going to be a higher frequency of anatomy that's not as favorable with bicuspid patients.
Right, right. I think that's very practical. Anton, one of the audience is asking, is there a lower age limit for TAVR? At what age do you say this patient is just too low risk for TAVR and should be undergoing surgical AVR?
Yeah, it's a great question. Can you hear me?
Yes, we can.
You're directing that question to me, is that right? I would say anything really under 65 and a low risk, I don't think we should be offering TAVR to at all. Of course, there's things to consider, but by and far, I think under 65 is really, you're doing a disservice to the patient if you're offering them TAVR and they're otherwise low risk. As you get closer to 70, I think the scales start to tip a little bit. Maybe there's some equipoise there. I know the recent European guidelines kind of use that 70 cutoff. But I think under 65 really should be going for surgery if they're low risk.
Right, right.
Can I make one comment?
Please, John.
Yeah, so I agree at baseline, but I will say that, part of it, if in patients who are under 65, if you're going to be putting in a bioprosthetic valve and not a mechanical valve, I think a lot actually depends on sort of what's going on with that patient. I've treated a number of patients now that are still, work actively as firefighters and volunteer firefighters or police officers or other things, who know they're going to need surgery at some point, but say, look, if I can, I'm 54 now. If I can have surgery, if I can work for another 6 years, I get my full pension, I can then retire. Let me have surgery when I'm 64. That's fine, but get me, 8 or 10 years out of this valve and then do that. I don't think that's an unreasonable thing to do. I really think that's where, you can say, like, we should tend to do this, but I think we should avoid hard cutoffs in people in general and really focus on that individual patient.
Yeah, I think that's true. And not to get on your case here, Anton, with both John and I. The only comment that I would make, though, is, and this is a transcatheter course, so it's not the forum, but the clear distinction is to understand that a surgery at age 60 does not mean that we can do valve-in-valve TAVI at 70 or 75 or whatever, right? Because I think that there is less understanding, in truth, at pre-procedural, preoperative planning with CT on the surgical side than what we have learned in the TAVI side. So it's not uncommon that I get a patient who has had a root enlargement, a 25 or 27 surgical valve. And what tends to happen, right, is that once they close the aorta, they close the chest, the valve cants a little bit toward the left main. And now we have a 2-3 millimeter distance VTC from the surgical post to the left main, and the left main is a little bit lower in the sinus. And so, sure, we can modify the leaflet and do valve-in-valve TAVI, but I think if we're going to be advising all these 60-year-olds to get surgery, we need to make sure that the surgery is going to allow a valve-in-valve in the future.
Yeah.
Yeah.
And I agree with that completely. And I think Dr. Forrest example was spot on. I mean, you have some people, like you were saying, who are young and you think they'll be great TAVR explant candidates in a decade or so. I think that's a real conversation. And I agree. I've actually had similar conversations about different valves for these patients as well.
Yeah. I think you guys highlight all the important parts about individualizing our decision making for the patient. And I agree with you, John. I've done TAVRs in under 60-year-olds. I mean, I actually had a physician recently who he's still in active practice, and he said, "Listen, I know this. I'm going to need open heart surgery, but I still want to work. I'm very productive. I have a busy practice. I don't want to be out of it for the next few years. And then when I retire from my practice, you guys can do whatever you need to do to explant the valve and give me a surgical valve when it degenerates." So I agree with you. We need to make individual decision making. And I also think, the other thing we don't talk about, which Amr is highlighting a little, is it kind of needs to go both ways, right? I mean, we need to know that our surgical colleagues are planning for the future, right? And planning in, how we treat a patient. I mean, I just saw a patient this week who was told, "Oh, don't worry, I'm putting in a perfect valve for you that will allow future TAV and TAV." And now the patient came to see me, 10 years later, and the valve I have to do a valve and valve on is a Percival, which is not the easiest and nicest one to do it on. So I think we need to, continue to evolve the field and grow it across both. I mean, the whole heart team concept needs to, I think, extend across both sides so we give patients the best options. But there are a lot of questions coming in, Anton, about TAV and TAV. So I think maybe the best way to address some of these questions is for us to go to your talk, and then we'll see what we're missing.
Yeah, perfect. Okay, can you guys see my screen here?
Yep.
Yes.
Perfect. All right, so hello everybody. I'm Anton Kamaj. I'm a interventional cardiologist in Mount Sinai Morningside, part of the larger Mount Sinai Fuster Heart Hospital here in New York. I was asked to give a talk on practical considerations in redo TAVR, so here we go. I don't have any disclosures. And just to kind of kick us off, TAVR growth in patients under 65, at least as of 2021, in the US was kind of 50-50. Tremendous growth there in that age group. And I think we're probably past this 47.5% number we see here. And as we alluded to in our little conversation there, these patients are going to outlive their valves, particularly these younger patients. And so there's going to be a wave of patients coming back with failed transcatheter valves, and we're going to need to do something about it. And so at least in the US, the current commercially available TAVR valves are shown here, and just some basic concepts about these valves as we think about redo TAVR. For the SAPIEN platform, we know it's an intraannular design. It's a balloon expandable valve. The valve goes up to about 23 millimeters in its largest size, and the leaflets will extend to pretty close to the top of the cage, and you otherwise expect to have a linear diameter throughout the length of the SAPIEN platform. If you go to the Evolut platform, it's superannular design, as we all know. It's self-expanding. The frame height goes up to 45 millimeters, and leaflets can extend up to 25 or 26 millimeters from the bottom of the valve. And the diameter varies as you go along, up and down the valve. The Navitor platform is intraannular design and self-expanding. Its height can reach up to 50 millimeters, and the leaflets extend up to the commissural tab that's shown there for you. And the diameter tends to be linear until you get up to the crown of the valve. And so a lot of combinations to at least think about when you're doing redo TAVR, but I think the most common ones in practice are likely a short and short, a tall and short, or short and tall. I haven't done any tall and tall. I haven't spoken to a lot of people who've done many of those. So for the sake of this talk, I think we can talk about the other combinations. And so for TAV and TAV, key considerations to think about. So the name of the game here is avoiding coronary obstruction or sinus sequestration. This tends to be a little bit more concerning with failed evolutes because the leaflets, like I pointed out, will extend much higher. The mechanism of your index TAVR valve failure is important to understand, and that can kind of drive your procedural strategy. The choice of your second valve obviously has a lot of implications. I prefer doing the opposite of the initial. So if you had a short valve initially, maybe doing a tall one for your second valve, and vice versa, doing a tall and short. your implantation depth will have a lot of implications related to your coronary obstruction risk. And then when you're thinking about coronary obstruction, it's important to understand how your commissures and coronaries all align, because that may, prevent you from getting a really good leaflet modification done. And then TAV and TAV interactions are unpredictable. And so this will kind of influence how your procedure goes and how you should think about performing your procedure. So valves can fail for a number of reasons. It could be structural or non-structural, and these include stenosis, regurgitation, or severe PVL, severe PPM. These patients tend to be candidates for redo TAVR, although not always. But patients presenting with valve thrombosis or endocarditis typically are not redo TAVR candidates. So I thought I'd present a case, just kind of walk through how I went through about this case that we just did last week. This is an 82-year-old man, had a 29 millimeter Evolut placed in 2019. He presented to the hospital here last month with heart failure. We confirmed transvalvular aortic regurgitation through the valve. The mechanism here was the non-leaflet was prolapsing into the LVOT. A ton of comorbidities for this gentleman. He had CAD with prior stents in the left main, the LAD, and the circumflex, which is also anomalous and comes from the right coronary cusp. His RCA is totally occluded, is collateralized by the LAD. He has an EF 40%, AFib on Eliquis at home, no left bundle. He's on insulin, yes, CKD, and his CTS score was 6.7%, which I think underestimates his actual surgical risk. So when you're talking about redo TAVR, you really need to focus on your CT planning, and there's a lot to consider. So you need to know your index TAVR in vivo dimensions. If available, if you have the index CT, it's also valuable to understand the native annular and LVOT dimensions. You need to determine your risks of coronary obstruction. You need to evaluate the extent of calcification at the aortic root. And then you also need to understand whether or not coronary protection or lethal modification is feasible for these patients. So getting started, step one, I select my CT phase. I tend to do this in the diastolic phase. I think this allows you to kind of visualize your commissures a little bit better, whether you're doing TAV and SAV or TAV and TAV for that, I should say. This contrasts with native TAVR, where you usually do the systolic phase. And then I label this as my neoannulus or node 0 if it's a failed evolute. And you can see here that the area is 418.5 with an average diameter of 23.2. And so then what I do is I measure the area at each node level, at least for a failed evolute. And what you can see, it's hard to see here, but the area basically tapers as you go up the valve, and then it starts to expand as you get out to nodes 5 and 6. But what you can appreciate here is the leaflets do not appear very calcified, which fits with the patient's presentation. And the valve appears to be pretty well expanded. Now, if you had a failed S3, you want to take 3 measurements: the inflow, the midframe, at the outflow. And in this case, you can see the midframe is a little bit crunched compared to the outflow and the inflow. And this was another case that we worked up recently. So next, you want to pick your redo valve size and type. And so when you do an S3 and an evolute, I like to take the average area of the nodes that you're going to be covering. If you're going to implant low, it's really important to get your neoannular area, because that's probably going to be the widest space, and you don't want LV migration. If you can get your original TAVR measurements, that's also helpful. But just for all intents and purposes, I like to downsize my S3 by at least 1, if not 2 sizes. So for example, putting in a 23 S3 and a 29 evolute. If you're going with evolute and S3, you need to use the average area and perimeter at the inflow, midframe, and outflow. And generally speaking, this is kind of like a 1-to-1, where you put a 23 evolute and a 20 sapien, or a 29 evolute and a 26 sapien. And for an S3 and S3, I generally go 1-to-1, so putting a 26 inside of failed 26. Next up, I measure my coronary heights from the neoannulus or node 0 to the inferior margin of the coronary, and this establishes our coronary risk plane. And so you can see here, I've done that for the right coronary artery, the anomalous circumflex, and the left coronary artery. And then I simulate my implantation depth to determine the neoskirt plane. And so here I've modeled a 23 S3, and I've modeled it at different heights along the evolute. So here to the left, you can see the outflows out to node 6, and in red, is the neoskirt plane, and you can see both coronary risk planes fall below that. And so both coronaries are at risk if you choose this strategy. If you go to an inflow to inflow strategy, you're almost like outflow to a node 5. You can see that your left coronary seems to be safe, but the RCA or the left anomalous circ appear to be in danger. If you go outflow to node 4, so again, a little bit lower, you can see that the RCA or circumflex coronary risk plane is just above your neoskirt plane there. So maybe a little dicey, but you do get some leaflet overhang here, and your left coronary is totally safe. And then if you go outflow to node 3, both coronaries are probably safe here. You're going to get a ton of leaflet overhang, and you also risk some LV migration. So here you want to assess your risk of coronary obstruction, particularly when your neoskirt plane is above your coronary risk plane. So if you go outflow to node 6, you can see the VTC and VTSDJ in this case are both nothing for the right coronary and the left circumflex, but you may have some wiggle room with the left. If you go inflow to inflow, the VTC to the anomalous circ is 2.9, so that one is probably prohibitive. And then if you go, there's a typo here, but it should say outflow to node 4, your VTC there is about 4.5. And so generally speaking, a VTC of over 4 is considered low risk. But the problem becomes, even in these cases that are kind of borderline, is you don't really know how your index TAVR valve is going to respond to your second valve. So what that expansion is going to look like. And so those are just some things to consider. In cases with severe AR, one question I have, and maybe we could talk about it after, is how okay are we with leaflet overhang in patients who present with severe AR as the primary mechanism of failure? And if so, how much overhang are we okay with in these cases? So next up, you want to look at coronary commissural alignment. So if we were to put this valve or place this valve a little high, can we modify that right leaflet? And what you can see here is the anomalous circ is basically right next to the right non-commissure, and our coronary alignment is very severely misaligned. And so leaflet modification may not do what you would theoretically intend it to do, but there is this concept out there that you may at least fill the sinuses and improve sinus flow, and that may be okay as well. Whereas on the left side here, there's very mild misalignment. And so if you needed to modify that left leaflet, I think you'd be a-okay to do so. So now you got to pick your plan. And this is just the slide that I showed you earlier. So do you want to modify both leaflets and aim high? Do you want to go a little lower and modify the right? Do you want to go outflow to node 4 and maybe protect that anomalous circumflex, putting a wire down? Or do you want to go outflow to node 3 and risk a lot of overhang and LV migration, but you don't have to really be worried too much about coronary protection? So here is our strategy. We do all of our valves under general anesthesia and TE guidance. In this case, we went with our outflow to node 4. We use a 23 S3 Resilia. We added 2 cc's of prep. We put a wire down the anomalous circ, and I'll show you in the next slide. We also have a guide extender with a stent there just in case. We did not opt to predilate this case because the mechanism of failure was regurgitation. Maybe consider it in cases of stenosis. We're also worried about causing coronary obstruction with just the predilation or even the post-dilation. I've seen that happen even when you're doing a basilica and you still get the coronary obstruction when you post-dilate after. So I think in some of these cases, maybe not the best strategy. So here's our deployment. And what you'll notice about this deployment are some critical considerations to really think about. So you want to ensure optimal frame alignment of your index valve. And so what you can see there is you can appreciate all the nodes, so you know what node level you're at. You want to do a very slow and controlled deployment. You might want to ask anesthesia to do a breath hold as well. This will help with allowing you to manipulate the valve as you do it. If the valve starts to move on you while you're deploying, the important thing to know is you want to push and pull on your wire as opposed to pulling on the delivery system to move your valve. So you'll push on the wire to go more aortic and pull on it to go more ventricular. The other caveat here is in patients who have a very low EF, in cases like this, should strongly consider upfront support such as ECMO or LAVA ECMO, something like that. because these patients may not be able to tolerate these long, prolonged runs of pacing. And so, but next, here's a selective shot of that circumflex, and you can see as TIMI3 flow. So that went okay. And so just some practical takeaways. Redo TAVRs, an increasing part of every TAVR program. Minimizing risk of coronary obstruction is the name of the game. Your second valve choice and placement of it will have a lot of implications as to kind of what happens here. So I would recommend that you do a systematic CT analysis to really over-prepare for these cases. And I recommend doing your own CT workup because that really allows you to appreciate and understand the anatomy you're dealing with. In doing so, you need to establish your coronary risk plane and neoskirt plane and assess coronary risk when the neoskirt plane is above your coronary risk plane. There's a lot of strategies to mitigate this risk. There's a bunch of different leaflet modification techniques and devices out there now. So kind of pick the one that you prefer and like. I think snorkel and chimney stenting probably becoming less and less favorable out in the real world. And the other one, like we did, is you can just implant your valve a little bit lower and then weigh the risk and benefit of leaflet overhang and LV migration. When you are deploying, it's really important to do this slowly at a frame alignment view so you know where you're at in relation to your index valve. You want to push and pull on your wire for your positioning if you need to do so. And the expansion of the first valve can be unpredictable. And so pre and post dilation may not be a kind of routine strategy for all cases. So thank you.
Thanks, Anton. That was great. It was very thorough. I think you answered majority of the questions we had in the chat about CT and how to do this and what measurements are important. I think, some people were hoping there's only a few measurements, but I think the way you went through it about this detailed analysis is incredibly important. It's the only way we can really ensure great outcomes. And so thank you so much for doing that. John, I mean, from this presentation, if you see this, I hope we did transmit that doing TAV and TAV is something pretty complex. It's much more complex than the first TAV. Do you have some tips and tricks you want to share with the audience? I think Anton ended with a great slide, but I think there's also always a few things we can add to that from our own experience.
Yeah, I would say that I think one of the challenges that I think we face, especially in low risk patients, is that what you're going to face with your TAV and TAV implant in part depends on actually where your first valve ends up. And, if your valve ends up quite a little bit deeper, especially if it's an evolute, if the evolute ends up deeper than you would intend, what Anton showed there, if you put the sapien in sort of deep where the evolute is, you're actually, because the evolute where it's in the LVOT may not be making contact, you may have a little bit more tendency to end up ventricular. The other thing, and I think Anton focused on it nicely, but it's one of the reasons that I think it's helpful to downsize actually by two sizes. So for example, using a 23 and a 29 evolute, a 23 sapien and a 29 evolute, is because the waist of a 29 evolute is only 23 or 24 millimeters. And if you're using a 26 there, you have to be really careful that your balloon will interact with the waist of that valve. And as that balloon interacts with the waist of the evolute valve, it's going to have a tendency to push you into the ventricle. And that's where the wire position becomes really important. And so I think Anton walked through it really nicely there, but I would say those are the other things that you need to pay attention to: is how deep was your initial implant, especially if it's a self-expanding valve there. And that, I think, will alternate a little bit. Also, if it was a very high implant, so if your first evolute was at 0 or 1, you really don't want to be implanting the sapien valve at node 6 or node 7. You almost can implant that one right where the native annulus was, but again, there you have to worry what are your leaflets going to be if they're low coronaries. And so I think it's definitely a much more complex, both from the procedural aspect and also from the planning aspect for the things you have to look at.
Yeah, absolutely. Really not easy. and I think complex. And that's why I was wondering, Amr, I mean, do you think, there's going to be a role for simulation or AI here to make this decision making on how to do TAV in TAV, which valve goes in where, and what height, make that safer and easier for our colleagues?
Yeah, of using AI simulations. I think that once you take away the, you know, differences in CT quality and things like this. So if you assume we have a good CT quality and so forth, I like the idea of something like DASI or FIOPS or something like this because it makes it index valve agnostic, right? So it's not that the CT analysis is being provided by a particular company that has a certain interest in a certain valve. And I think the fact of the matter is that less than a third of people are actually looking at their own CT. So I think the way to make the understanding of lifetime planning the most democratizable is probably to use one of these third-party analyses. And they can give you a really nice sort of index valve placement, understanding the depth of implant in comparison to things like membranous septum and things like that. And then also simulate that for the future TAV and TAV experience and what's suitable based on the index valve. So I think that there's a lot of opportunity here. And I think it'll make the idea of lifetime planning much more uniform rather than, let's say, the handful of people that are looking at their own CT and making a valve choice based on that.
Right. Thank you. Anton, one of the questions from the audience was, when you're doing this analysis of the CT for a patient who has a degenerated TAVR, um, how often or what factors actually would then make you say that patient should rather have explantation? Or are there factors even where you'd say that, there is no treatment for that patient? Have you ever had to say, oh, I'm sorry, I can't actually do anything to treat your TAVR valve?
Oh, that's interesting. Um, in my short experience, I have not had a case where we've said there's nothing we can do. I think surgically, it depends on what the kind of surgeon is comfortable with. If how experienced your surgeon was TAVR explant. I know at Mount Sinai we have Ismail El Hamamzi, who I've yet to see him turn down a case like this. Um, but in our case, you have to look at the leaflets. So if you're worried about coronary obstruction in a patient with a prior TAVR, those leaflets are very, very calcified, kind of throughout. Leaflet modification may not be feasible because you may not even be able to cross. And so in some cases, I know some people are doing the surplus procedure, with mini thoracotomy, go and you cut out the leaflets and you implant a new valve. But I think it's a very difficult scenario. This one you have to talk to your whole team about and figure out what may be the best strategy. I personally haven't seen a case where they where we haven't been able to find a treatment for the patient.
That was a great talk, Anton, by the way, like really, really well done. I have a question. I get very confused by what is node 6, node 4, etc. So I'll just say closer to inflow versus closer to outflow. We have all these simulations saying, well, if you put it a little bit lower, you get some overhang, you should be safer from coronary obstruction. And at least in my experience, the Evolut platform tends to fail more with AR. And so maybe that all works out. But I have trouble really knowing how much data or how much understanding we have for those Evolutes that fail with calcium and AS. And I have to assume that we're not going to get the same kind of overhang and the same kind of safety. And so in those circumstances, what is it to keep the leaflet from going all the way up to 25, 26 millimeters? And how do you guys approach those cases, let's say differently? Do you just assume it's going to go all the way to the commissure, or do you think there's a leeway? What do you think?
Do you want to take that, Anton, first?
Sure. Yeah. So I guess Amr's asking, in the cases with stenosis and you implant your valve, do you worry about these leaflets going straight up, or do you think they will do a little bit of overhang? And I think in the very stenotic leaflets, I think you have to err on the side of caution and think that they're going to go straight up, because I think hoping that they're going to overhang might cause you some trouble. And so I would say in very stenotic leaflets, I think it's important to modify them if you need to. And if you can get away with not doing it, then I think that's also great. But I wouldn't count on leaflet overhang in the very stenotic leaflets.
Yeah, I don't think we have any data. So I think I have to send my patients to you guys because I have had a patient I've had to say no to for TAV and TAV, who was elderly, in her 80s, not a surgical candidate, and had no sinuses with coronaries low and a commissure sitting in front of the coronary. Honestly, I don't know what to do with that case because until I have a technology that will allow me to remove the leaflets completely, I'm not sure how to treat a patient like that because leaflet modification, I'm not sure helps when you have the commissioner right in front, and you can't snorkel either because I'd be snorkeling through the frame and then sandwiching my guide catheter between two valves. So, I mean, have any of you had to face that? I mean, or am I the only one seeing these more elderly patients who are not great candidates for TAV and TAV?
Oh, likewise, Azim. It's a horrible feeling, right? I mean, you just feel terrible when you encounter this situation. On the one hand, I'm fortunate that I have a lot of surgeons, like all of you have, right, that take care of really sick patients on a very regular basis. But there are those that simply are not suitable. And there are a couple of patients that I can remember that we've had to say, I'm really sorry, but let's involve, palliative care and hospice medicine. And I mean, that never feels great in the current era, right?
Right. No, absolutely. Absolutely. So when you guys look forward to, you know, Anton, you mentioned this is going to become part of all our practices. If you're doing TAVRs and you're doing them in low risk patients and you're in practice long enough, you're going to be seeing patients come back. So as you start thinking forward, how are we going to manage this increasing number of patients? I think we mentioned, very briefly, maybe simulation will help us understand how to treat them better. Any other things you think we need to be developing or you see in the near future that will help make these procedures safer and more democratizable? And that's really to any of you.
Yeah, I mean,
You,
I'm
Josh.
happy to take it on. I think the prior session was great, right? It was talking about advancements in leaflet technology and what can we do there. I think the fact of the matter is that we also, I've been in situations similarly, Azim, where you have somebody who's 92 and you did a TAVR 8 years ago and they've done great to 92. It's also, I think, important to recognize that as physicians, there comes a limit to what we're able to do, especially when patients get it often into their 90s and what makes sense there. But I think it is one of the exciting parts about medicine is looking for what can we improve on and what can we do better. There are some ways that we've done some innovative snorkeling techniques in those patients, but with mixed results. And I think what we need to continue to do is push for long-term data to understand sort of what the real world outcomes are of these valves and how do we then improve upon leaflet technologies, because that's the golden ticket there, right? The golden ticket is to be able to implant something that's going to last, even lasting, a third or a quarter as long as their initial native valve lasted would be great. Right now we're at 10% of what a native valve does.
All right. Absolutely. And there's a question from one of the audience about anticoagulation post TAV and TAV. Do you do anything different to what you would do if it was the first TAV?
Yeah, that's a great question. We don't have a lot of great data for that. I was fortunate that this patient was already on DOAC, so I sent him off on that. A lot of people I speak to in my practice for TAV and TAV is doing anticoagulation for at least 3 months if they can tolerate it. At the very minimum, I think dual antiplatelet therapy. These patients are dealing with a lot. They have the 2 metallic frames. They have their native leaflets that are old. They have the initial TAVR leaflets that are old. So there's a lot of kind of material in there. Your sinuses now are probably a little bit fuller, so to speak. And so theoretically, these people should be at higher risk of like thrombosis and things like that. So I would say at least anticoagulation for probably 3 months. dual antiplatelet therapy, I think, at a minimum.
Hmm.
What do
Yeah,
you
so that's
guys
what I'm
think? I
thinking
mean, what
about.
have you guys been doing?
Yeah, that's what I'm doing in my practice too. Maybe a little longer than 3 months, maybe 6 months. But
Yeah.
I'm also concerned about the neosinuses and neosinus washout and flow. And one of the things we haven't talked about is thrombosis. We really don't know what thrombosis rates are really in TAV. We're only starting to see the first now data from real world registries. And I think there are some industry sponsored trials happening, which will hopefully give us even more data because I'm sure those will be core lab adjudicated and have CC. So I think it's a space we have to continue watching, but it's a space with a lot of interest. And so, Amr, I think we're going to move on to you, have you close out the session with really showing us a demonstration of how we do TAV in TAV.
Wonderful. And you guys can hear me okay?
We can.
Perfect. So hopefully this dovetails nicely into Anton and John's talks. It's a there aren't too many slides. I thought I would go through a few sort of procedural learnings, but specifically, I'm going to stop in between some slides, and I think we can introduce discussion into the slides. Might make it more fun. So this is, I have no disclosures. So this was an 84-year-old lady who I treated about 6 years prior with a 20 millimeter S3. You can see there in the leftmost, she has sort of a mild to moderate ventricular dysfunction, sort of moderate prosthetic AS, and of course, severe valvular AR, as you see in the rightmost screen. You can spend a minute here in the CT analysis. So, I always find this interesting. This was a 20 millimeter valve that was deployed and actually dilated with the same volume at the time of the index procedure. And you see in the leftmost here, it measures about 17 to 18 millimeters in the short and long diameters. It looks like the valve to coronary distance is about 3 millimeters to the right and 3.5 on the left. But the sinuses measure about 25 to 27 millimeters, so some space around the frame. And if you look at more of a long axis or an axial or cross-sectional image, you see here that there's probably space to the sinotubular junction and the coronary, both on the right side and the left side. And the sinotubular junction is what I'm measuring here at an average diameter of about 26. And again, that was a 20 millimeter valve. Any thoughts that any of you have on this, and specifically with regard to concerns about leaflets or not, concerns about coronary obstruction or not based on the leaflets, and also thoughts on valve choice?
John, start with you, and then maybe Anton, if you anything different you would do to what John says.
I mean, you're in what I see here, I think you're going to be okay on the left side. It looks like you've got some room even above in the sinus there. The right may be a little bit more concerned. I still think you're probably going to be all right with that. I will say this is one of the instances where I don't mind putting a self-expanding in a balloon expandable valve. It does give you freedom to evaluate it, to open it up. It'll push it out of the way. It'll be fully functional, and you'll be able to, if there are issues, recapture it and come up with an alternative plan. I think in this situation you're going to be okay. I'd like to do a few more measurements. I can't quite see if you have commissural alignment or not with that. One option would be to do a leaflet modification for that right coronary.
So thanks, John. And to your point, and we'll get to that idea of opening the valve and assessing through the case, but this is where the commissure is here anteriorly. So essentially totally commissurally misaligned.
Yeah.
Here are the other two commissures. But okay. So, John and Azim have both heard me say this 1,000 times, but I will at least demonstrate my love of same-side arterial access anytime I have the opportunity. But this is how we do all of our cases, and I'll show you at the end why it's helpful. But this is a micropuncture needle near the top of the common femoral artery for our delivery sheath access. Once we place that, You can just see in the angiogram where we are in the CFA up here. You see the bifurcation is down here. So we can then put an inferior sheath about 2-3 centimeters below the delivery sheath. That's the second artery stick there. And that's what houses our 5 French sheath, through which we have our angiographic catheter for the root. But at the end, if you need to do some peripheral work, this really makes life easy, because you can actually never occlude your delivery site, because you'll always have the 5 French sheath sitting kind of up here. But we'll get to that at the end. So I don't know if people have thoughts or want to comment. I know we are a bit anomalous in using Sentinel all of the time for everything, but I don't know if you guys have particular thoughts on the need or not for embolic protection in TAV-in-TAV or valve-in-valve kind of cases. Does that change your calculations there?
Yeah, it's a great question. Maybe I'll take that one. Firstly, I want to say, between you and Nicholas Van Meeghem, you've converted me. So for the last 4 years, we've been unilateral access too, just so you know. You can take credit for that. But yeah, when it comes to Sentinel, I have to say, we used to be anomalous like you, and we're doing it in majority of our patients. It's been harder to do that recently with all the data, but we continue to do it in patients we consider high risk. So a patient who's undergoing TAV-in-TAV or valve-in-valve or bicuspid or any leaflet modification, we do use it more commonly. I don't know Anton, what about you?
Yeah, for Sentinel, we like to use it for all of our valve-in-valve or TAV-in-TAV cases. We didn't actually use it in the case I presented because it was a case presenting with AI, and the leaflets weren't very calcified. But I think if you have degenerated leaflets and you're putting in a second valve, we like to put the Sentinel in those cases, but not routinely for native TAV or otherwise.
Sure. Okay. So here's the initial aortography, and I'll pause it because I think there's a couple of things that I'd like to just point out here. So, okay. So first of all, you can see sort of where the index valve is deployed. It's sort of deployed it right at a 0 position in this REO caudal. I think to your question, John, about where exactly is the right coronary, I think that sometimes aortography, whether it's TAV-in-TAV or valve-in-valve, can be really beneficial, because we get some blooming artifacts sometimes from the CAT scan that we can't quite make sense of the correct or the accurate distance. So I think in the REO, you see here the ostium of the right coronary. It's kind of just at the V of the S3 frame. You see here, I think there's probably, or at least to my eye, more room than I appreciated on the CAT scan. So I found this to be helpful. And while I went into it hopeful that the right coronary was going to be okay, I found this to be quite reassuring. Secondly, based on the placement of this valve, of course, the patient doesn't have a pacemaker and so forth. I want it to be sort of as close kind of inflow to inflow as possible, maybe just a hair underneath the S3 frame to minimize risk of conduction problems coming out of the case as we could. Are there any thoughts from you guys on pre-dilation versus post-dilation, given all of this information, in light of the fact that it's a 20S3 and the frame essentially measures about 17.5 millimeters on average diameter?
Yeah, I mean, I don't think it's unreasonable to consider dilation of it. I do think one of the challenges is, you're going to change your geometry when you post dilate, right? And your coronary distances are going to change a lot there. And so I think part of my decision about whether to pre-dilate or even honestly to post dilate would come around sort of what are my goals for my second valve? How long am I trying to get out of it? And I would, in an older patient, I might actually choose not to do it just because you're going to expand out more and shrink your valve to coronary distance.
Gotcha. And John, before I get to the next slide, you and I have talked specifically about the benefits and the times to use a snare for valve-in-valve and TAV-in-TAV cases. I should have mentioned I was planning to use a 23 millimeter evolute to fix this. Is a snare something that you use routinely? Are there particular anatomic considerations that make you want to use a snare to help facilitate traversing the index valve?
Yeah, I mean, so right, I think this is talking about a snare as because the evolute won't articulate around the arch and you can't flex it. Part of that depends on how your initial valve is sitting there, and you're going to be sort of over on the greater curvature and what it's going to be like. I think in this case, you're going to be just fine. You're not going to. I wouldn't have worries there. I think with the single spine that's present on the current generation, it moves a little bit more easily than the prior generations do. The other time where you can get a little bit into trouble is if you have a significant aortic aneurysm, and there's just so much space in there as you're coming down. So in this case, I think I wouldn't choose a snare, but those would be some of the cases where you might do that. And again, that's going to be a snare from the other groin that you're then going to sort of put on the a third of the way up on the capsule and pull it so you can sort of more center it up as you're coming down the ascending aorta.
Gotcha.
I mean, it's
Very
not
helpful.
both.
And to just go ahead. Sorry, Izzy. Go ahead.
Yeah. Both of you are favoring, doing a supraannular tall valve here. Do either of you, any of you have experience? I don't, so I'll be honest, with using a Navitor in this kind of anatomy? And with, a 23 Navitor inside this 20 millimeter S3?
I'll be quite honest. I only, just because it doesn't have the indication yet, I only used it one time, and it is simply because the folks from Medtronic were not there, and the folks from Abbott were there, and I needed to use a self-expanding valve and in a small valve-in-valve, and I did, and it actually worked out quite nicely. I do find that the gradients of the Navi, despite the fact it's intraannular, do tend to be more favorable on the echo. And so I think there's probably some role for it, but I've not used it in this application particularly.
Yeah, the reason I was asking is I spoke to Ollie the Backer the other day, and he was saying that Navitor has become his preferred platform for valve-in-valve, so in surgical valves. So I just wondered if any of you had an experience in valve-in-valve.
I mean, I'd love to see more data, as that develops, because obviously it would make our lives a bit easier from future standpoints with regard to commissural height and so forth. It's interesting.
And especially when you think about, having to use a snare to be able to navigate the arch and so on, because it doesn't have the delivery system much softer because of the opening force of a Navitor. I find it very flexible going around the arch. So I think we're going to have to learn some more.
Yeah, true. And the other thing I would just comment to dovetail to John's about the snare is that you can also, I tend to use the Evo through, not via the inline sheath, but I tend to put another sheath just for exchanges and BAVs and so forth, and to avoid those. So you can just upsize by one. So if you're going to put a 23 Evo in like an 18 Gore, you can instead put in a 20 Gore, and then you can just put the snare around the Evo capsule as you're putting it into the sheath to avoid having to come from the other groin and do that. One of my colleagues likes to do it from the left right. So, okay.
Well,
so
go ahead. Can you address the one question that came up because you brought it up, was the pre-dilatation? When do you pre-dil, and someone asked, are you ever concerned about causing AI with a pre-dil when you do TAV-in-TAV?
Yeah, I get concerned about causing AI for TAV-in-TAV and valve-in-valve. So in truth, I also think that there's at least some of the benchtop data that had come from Janar and Stephanie's group in Vancouver a few years ago, that there's probably an overall better valve expansion with post-dilation. This is, as opposed to the pre-dilation before putting in the second TAVI. So I always post-dilate. I also think, for what it's worth, in Santiago Garcia's TVT analysis that demonstrated, slightly worse outcomes in valve TAVI for those patients who had a valve fracture before the TAVR was placed. I don't know if that has to do with some issues either with root trauma or causing AR of the surgical valve. So I don't ever dilate before placing the TAVI.
Right. Thank you. I think that will answer Samina's question. Thank you.
So thank you. So this is, John, I had your same opinion. It's a somewhat vertical aorta, and it's a double curved Lundy. So I thought I would, it would be a smooth sail through the valve. You'll see here, as it goes through, we are getting a bit stuck at the outer curvature. And so you'll see it come back and just try to readjust the wire a little bit. You can see the patient is also wondering what we're doing. She moved her head a bit, but now it finally got through. So it wasn't a huge struggle, but it does make me think sometimes more about using the snare universally, especially if it's just going around the sheath. So here's the first valve deployment, and I've put the hemodynamics here. You see that as soon as we start expanding the valve, she has nothing, like no pressure, and she doesn't like it. And you can see the valve it's a little bit lower than I had wanted it to be. And I kept opening to the rumbles to kind of decide and reassess. As you see, she did not like this at all hemodynamically. And so I just went back, recaptured it, and said, look, I don't, it's a little bit lower than I want it to be. So I'm going to recapture, try to implant it a little bit higher, a little bit more sort of inflow to inflow-ish. But, gave her a few minutes to just recover from that, which she did. But it just brings up the point that I think that there is something different about the TAV, and maybe it's because all of the space there is so constricted, and this is a 20 millimeter index valve and everything else. But I have found that I have less leeway from the hemodynamics perspective to just sit there at the rumbles and spend some time thinking and talking. I don't know if you guys have had similar experiences, because this is not the only time this has happened. I don't know what your thoughts are.
Yeah, for me, absolutely. I think it's a different anatomy to treat, and I think also you have less room, and I think Anton tried to bring that out very carefully in his presentation about it's not as easy for me to hit the target I want to hit when it comes to TAV and TAV, because I kind of feel once the two metals start interacting with each other, like the minute that happens, it's done. Like I have no more control over where the valve's going to end. So particularly with self-expandable, like starting exactly where I want to, and trying really hard that opening part and the flaring to get that right, because after that, I'm not going to be able to do much or change much.
Yeah. So any other thoughts on that idea, Anton or John? Okay. So
I think you're spot on with the hemodynamic changes. They in my experience as well, they don't really tolerate these things well. And so when you're doing, especially in the case of like a new S3 and you have to do these long pacing runs, it gets a little scary.
Yeah.
And then to what Azim was saying with the valve to valve interactions, particularly when you're putting in an evolute in a sapien, or I guess I haven't done evolute but evolute and sapien. I guess kind of your angle of approach is also very important. How perpendicular you are with the index TAVR, and are you kind of coming in at a strange angle or not, and that might affect kind of how things unfold for you.
Absolutely.
And honestly, I've had to do a few times tall and tall, and the ability to put the valve like higher inside the first one is almost impossible. It just tends to want to go follow the shape of the first one, and so I always ended up more or less where the first one was. So it's even more challenging. It's rare. I haven't done it anymore, but in the earlier days of TAVR, when we still were not getting valves where we wanted them, and we had some acute failures, we did some tall and tall. It's really even more challenging, I find.
Interesting. Cool. So with obviously, I wanted to put it, as I said, a little bit higher, but I was also feeling, a little bit squeamish because I was thankful that she came back just with a little bit of, eight of norepi and some time. So here's the second deployment. You can see we're starting it up just a little bit higher, kind of trying to mirror the inflow to inflow. You see as it expands, it goes just a tiny bit lower than that, but I think still with this S3 at a 0 point, the gold dots are we're about 3 millimeters deep, and I think that's okay. She did not tolerate this at all. So you'll see here, this is the rumbles, and we just immediately deploy it because I didn't want to recapture again, but she had absolutely no pressure, and in truth, did not really come back from it. So thankfully, one of our cath lab nurses quickly got on the chest in order to circulate the medicines that the anesthesia team had given, and within about 25 seconds, she was sitting here with a blood pressure of 120, and we all and the patient were much happier. But again, just to the point that Anton has already brought up and we've discussed about just being prepared for the hemodynamic instability that I think is very likely to ensue, and I think especially in these self-expanding in short frame valves, as we've discussed. So which gets a, oops. So here is, sorry, let me just play these. So here it is. So here's the 23 valve inside the 20 S3. I think you can appreciate fluoroscopically, how it's clearly a very underexpanded valve. These are the gradients of the valve, 32 over 15. Any thoughts one way or the other as far as post-dilation?
I would definitely post.
I mean, I think it makes sense.
It looks.
Yeah, it makes good sense.
And I will give you the
there. I think.
I was just gonna say I'll give you the information. I'm not trying to trick you. I did an aortography, which I think I did not include on these frames, but no concern whatsoever from a coronary perspective.
Yeah, I'll say with Evolutes, there's if anything, that with regards to durability and also with hemodynamics, there probably is there potentially is some benefit in getting them fully expanded. I think actually with probably sapien valves as well. If you implant a sapien and you give it all and there's a lot of valve constraint, I think you want to try to get that valve expanded some. You don't need to over expand this Evolute valve, right? You can take an 18, right? You can take an 18 balloon and open it up there, but I think even with an 18 balloon, you'll see it expands well. So you're not really trying to so much stretch the frame of the sapien that's there. You're really trying to expand the frame of the Evolute valve to have it come out to the sapien. The only other thing that I will just add here is that those hemodynamic things are fairly common. I never like having to give chest compressions afterwards. So one of the things we do in these cases is we actually just take a pigtail catheter, stick it down there, even though we're not doing aortography, and give our little bit of epi through that, because then you don't have to worry about it circulating around. So we keep a little bit on the table exactly for those settings.
Fair enough. So I know we're getting to the end. I'll close out here. So John, to your point, we did use an 18 balloon. I was also a little worried because I think it's very unpredictable how much does the index valve expand. And even though I was happy about the coronaries, I didn't want to be hyper aggressive. So this was an 18 true. And I think you can see at the end of this that, the EVO expands, but then it does recoil. And so here's the aortography. I still felt good about the coronaries, but I didn't feel that great about the expansion of the EVO frame. This was a gradient. So they went from 32 over 15 to 17 over 8. So I did actually end up taking a 20 millimeter true balloon, not at high pressure, just, balloon fill volume with the 60 cc syringe. I would like to think, at least to my biased eye, that the valve expansion is better, both on the index S3 and the EVO. You can see here's kind of the final expansion. I think it comes out much more close to the frame of the S3. Our final gradient now down to 13 over 7. And so we completed with that. And then just to close out with the idea of the same side access. So this is a different patient, not the patient I just mentioned. But if you see this, this was a subtotal occlusion just from the PER closes at the delivery site. So you have the inferior sheath going in about here. It ends here. So this, could have become occluded if we didn't have a sheath across. All we need to do is put our typical, table J wire up to the aorta, inflate a 6 mm balloon here, bring it back to the sheath, pull everything back, dilate this area right here, which is our delivery occlusion or subtotal occlusion, and that's there. So, it's a 2-minute intervention rather than having to cross over and so forth. So I find this very, very helpful. To summarize, I think it's important to understand balloon expandable valves are not usually expanded to the labeled size and how that might affect your future procedure. We've already discussed the use of a snare and hemodynamic tolerance. I think post-dilation is imperative for a proper expansion, but I do agree with Anton's point. Maybe it's not always the right thing, especially if the valve failure is AR and a self-expanding valve. Maybe it's not necessary. As always, I think same-side femoral access facilitates peripheral intervention. I think there's a lot of angst for people to put in 20 mm S3s, but this lady had a 20 mm S3, 6 or 7 years prior to this procedure. I don't think that a self-expanding valve at that time would have allowed her to get a TAV-in-TAV at the age of 84. And she was not a huge lady, so I thought that a 20 mm, even at the index time, would have been appropriate from a hemodynamic perspective. So just to keep in mind. But thank you very much.
A fantastic case. And again, I want to highlight just one brief point that both you and John mentioned. If I had to think of one of the things, like one of the top things that have changed in my practice in TAVR over the last 4 or 5 years, it's been the recognition that under expansion of these valves may limit their durability and may lead to thrombosis. And I keep that in my mind every day when I'm just doing a normal TAVR. But when it comes to doing TAV-in-TAV, it plays very heavily that thought in my mind. So I wanted to thank you both for highlighting it. Guys, our hour's flown by. This has been an incredible session. We went from, how to do individualized patient decision-making in low-risk patients to going through really step-by-step how to work a patient up for TAV-in-TAV, the complexities involved in analyzing the CT, and then really seeing a step-by-step procedure from Amr on how we do some of these cases with some of the complexities and decision-making that's involved. So listen, thank you so much. I learned certainly from being here, and it's always fun being on a panel and discussing stuff with all of you.
Thanks so much, Azim.
Thank you so much.